we asked a group of guys and their families to share their experience of testicular cancer and germ cell cancer, from diagnosis through to survivorship. It's in the experience. I'm Sue Brand. I'm a former testicular cancer nurse specialist from the Oncology Centre in Bristol, and I'm also the chair of It's in the Bag.
My name is Dr. Lara Gibbs and I'm one of the doctors at the Bristol Testicular Cancer Service. So testicular cancer is a germ cell cancer, of which there are two main types and some more unusual types. It is normally something that becomes symptomatic in the testicle, but in other circumstances more rarely can present in other places in the body. It's a curable cancer, and that's the main message that we try to get out to men, predominantly from the charity side of things. And therefore we encourage people to regularly examine their testicles on a monthly basis if they're able to remember, because picking it up early is important in terms of curing it. So if someone has found a lump or a new sensation or a pain or anything that they're worried about in the testicle, it's important to explain exactly what that is to the GP. No symptom is a stupid symptom. Sometimes they are quite non-specific, the symptoms, and it can just be a subtle change like a heaviness or a pulling sensation. Sometimes people have found an individual lump, but it's important to be honest with the doctor. They will usually then examine you, and if there are any concerns, they will refer for an ultrasound scan of the testicle, and that's a very straightforward investigation which is not painful but can help to then lead on to what we need to do next. So an ultrasound scan would involve you lying down on a couch, and usually a radiographer or sometimes a consultant radiology doctor has a probe that looks a bit like when a baby gets scanned, and they will pop that with a bit of gel onto the testicle and look around at both your testicles and to the lump above it, which is called the epididymis, and then sometimes into the groins as well. And then they will report on whether they think there's anything abnormal.
If the ultrasound shows, and it's around about 100% very good at knowing whether this is a tumour and it needs to be removed, you'll see a urologist, and the urologist is a surgeon that talks to you about having your testicle removed. It is best to take the testicle out rather than do a biopsy, because biopsies, if it is the cancer, can spread within the scrotum or the ball sac. Once you've seen the surgeon, they'll talk about having the operation, which is really odd because they take your testicle out through your groin rather than through your ball sac, which you believe they should do. But that also is so we don't have spread of the disease into that area. So they go into your groin, and that's when you come round, your testicle will be gone and there will be a scar in your groin. At this time, they sometimes offer you to have a false testicle placed in. We recommend that you don't do this straight away and wait until after the operation and get healed up. And then if you feel in months, years' time that you're not happy with being a bit imbalanced, you can have a prosthesis, we call it, placed in. But they're not always successful.
So in this type of cancer, in testicular cancer, there are certain proteins that can be released from the cancer that basically lead us to see increased markers in the blood. So those in particular are called AFP, LDH and HCG, and essentially they are something that in a normal person, if you measured them, would be in what we have a normal limit. And if you have a testicular cancer, sometimes, but not always, they can be raised. They help us not just with diagnosis, but also with ongoing monitoring. And if they're particularly raised, then sometimes it helps us to change the treatment decisions or to help guide the discussion about what treatment you may need. They would be done before an operation, but also after an operation, because in some circumstances, if they're raised beforehand, they can come down afterwards. So everybody who gets this diagnosis gets a CT scan. It's not something to be frightened of or that's out of the routine. The reason for doing it is that testicular cancer, like most cancers, can spread from where it started. Often that is to the lymph nodes in the abdomen and pelvis that run up the side of our main blood vessel called the aorta, but it can go to other organs as well. And so a CT scan would be of the chest, abdomen and pelvis, so the whole body, to assess how far the cancer has spread, if it has spread at all. So after the operation and when you've gone home from hospital, that's quite an uncertain time for a lot of patients, and that's because we as a team in the Bristol Testicular Cancer Service have to gather all the information about each individual patient who has a testicular cancer diagnosis. What happens is that once the surgeon has done an operation and they send the specimen or the testicle that they've removed to the pathology lab, and that is analysed by a histopathologist, which essentially means looking down the microscope and establishing whether it is a cancer at all to begin with, and also what type of cancer that is. Also, the CT scan would get reported by a specialist radiologist, and with all that information alongside the blood tests that you've had, all of that information, once it's gathered, is brought to our multidisciplinary team meeting. Every single patient is discussed there, and we gather as a team of doctors, radiologists, our specialist nurses, the surgeons, oncologists and histopathologists, and we all meet and everybody shares their expert knowledge on that specific thing. And the outcome of that is that we make a decision and document it on the cancer registry, so it is always there and it's in black and white, what treatment plan we recommend for each patient based on the information we have. If there's incomplete information, we sometimes request more tests, but often we're able to make a decision at least about what we want to discuss and what options each patient has. We're lucky in Bristol in that we see people often the same day as the multidisciplinary team meeting, if not only a week or two later. And so the discussion that's been had is very fresh in the clinician's mind, and we're able to give them all the information on that same day.
Chemotherapy for testicular cancer is quite intensive. Whilst it isn't months and months like some chemotherapies, it is a period of weeks, maybe 9 weeks or 12 weeks or even 15 weeks of the most intensive treatment that we give for a solid tumour. It is boring. It gives you fatigue and it does give you side effects, but the biggest side effect that most men say is boredom. To sit and watch a drip go through for 8 to 10 hours every day for maybe 3 days or 5 days is exasperating. You're often worried at this stage that chemotherapy is going to work, but also you're worried about your family and about the travelling and about you can't work at this time because it's so tiring. You do get other side effects which the doctors will explain in detail, and we also put a line in your arm so that you don't have to have lots of needles, and that will be your best friend because there are a lot of needles involved with having chemotherapy.
In general, we support people very closely through the chemotherapy because a lot of our chemotherapy regimens in this type of cancer are inpatient regimens. So people will often come and spend 3 to 5 days in hospital, and the length of the treatment will depend on exactly individual cases and how far the cancer has spread. But it can be anywhere from 1 cycle of chemotherapy all the way through till 4 cycles, or sort of 9 to 12 weeks of treatment. We very closely monitor people on treatment and see them in clinic before they go ahead to the next cycle. And we do blood tests. And the other thing to say and to expect if you're having chemotherapy is some investigations before you start, because we like to do some baseline investigations to assess basic organ function before we go ahead and make sure that people really are fit to cope with the doses we're going to be prescribing.
A retroperitoneal lymph node dissection is a large operation to remove some lymph nodes from your abdomen. Sometimes after we give the chemotherapy, the cancer cells don't look like they've gone completely, and unless we look at them under the microscope, we're not sure whether that's happened. So if your CT scan after the chemotherapy shows that there's still an area of tumour that's present there, to make sure that it's gone, we take it out with surgery. This is done in Southmead, and this is the biggest specialist centre for this type of operation in the southwest. All patients, whether they come from Truro, whether they come from Gloucester or Cheltenham, have to go to Southmead to have this done because the specialist surgeons are really good. The operation takes around 6 to 12 weeks to recover from, but sometimes men are lucky to have this as keyhole surgery, and we are the only centre in the UK that are doing this operation. We don't do radiotherapy very often, and when we do it for specific tumour, which is seminoma. Seminoma is very responsive to radiotherapy, and we don't do it for non-seminoma. It targets the area that we want to treat, and sometimes we treat after we do something called a PET scan, which shows up seminoma as being active, and it makes it look like it's all heated up. A bit like when you look at the thermal cameras that firemen use when they're looking in buildings. Very similar to that. And when you look at the scan, if there's a hot area, we often do some targeted radiotherapy to that. Some men don't require any other chemotherapy or radiotherapy, and so what we do is we stage them to say that they actually have a programme of surveillance that actively looks to see if the cancer's come back. To do this, we have to do it regularly, so it's really important to turn up for those appointments because we're actively looking on scans and on blood tests to see if the cancer has come back, and if it has, we can treat it very, very quickly. For some men, this means coming to see the doctor every month for a year, and for other men it means 3 monthly.
We know quite a lot about the natural history of testicular cancer, which is meaning that we know that within the first 2 years of having a cancer like this, the risk of it coming back is highest in that time. The risk then reduces over a period of time, and that's why at 5 years we often discharge people, because we know, particularly if they've had the treatment with us, that the chances of it coming back and causing problems anywhere are small. However, it's not completely unheard of that people can relapse after that. So we know that this is a curable cancer, whether it's just in the testicle or if it's spread to another place. And so doing surveillance, and when we say surveillance, we mean surveillance. We need people to come to the appointments that we book for them. Essentially what we're trying to do with surveillance is catch any changes, i.e. spread of the cancer or recurrence of the cancer, at a stage where it's very treatable. It is unusual for anyone to have untreatable testicular cancer, but we do not want to lose people to follow up and find that they're very, very unwell when they then have a recurrence. What we want to find is a subtle change in a CT scan, a subtle change in blood tests that we can rapidly investigate and treat before it gets to a point where someone is unwell from the cancer, and then their chances of coping with treatment or being cured are lower. The surveillance programmes are incredibly important, and sometimes we chase people repeatedly to come to our clinics because if you're well and you're working and you're a busy person, it's a bit of an inconvenience to come to clinic. But actually, normally they're a good news clinic. We do some blood tests. We see people often very briefly if they're well. And the frequency of appointments gets less and less the further out from your diagnosis you go. So I've never been part of the Survivorship Toolkit Day, but the feedback from patients is excellent. Even people who have previously been slightly sceptical about going on a day that's named like that. I think it's a very complex time having had a cancer diagnosis, particularly in people who are young, working, have families, they've got busy lives, and all of a sudden a cancer diagnosis comes along and just stops them in their tracks. There are a huge number of psychological responses to that, and it's very personality dependent how people cope with it. Hopefully the appointments with us are reassuring, and the chances of cure are very high, and all those things are good in the broader context of cancer itself. But having a time outside of the cancer clinic, which is very clinical environment, you know, you have to come to the hospital, you're having blood tests, you're a patient, you're not you. And going to a separate day where you can be you can meet people who've had similar experiences or different experiences with the same cancer can be invaluable. There's a chance there to talk about anything and everything involved with the cancer diagnosis, the specifics of treatment people have had, but also returning to a normality having had that diagnosis. And I mean, alongside those things, part of our surveillance is to run a holistic needs assessment clinic, which is where the nurses get a bit more time to sit down and chat through some of the psychology of the cancer diagnosis and all of the aspects of your life that might affect. as well as the specific symptoms and side effects of treatment that you've had. And so that tries to cover some of it, and the Survivorship Toolkit Day in my mind is a sort of extension of that, to help people to normalise it actually and get back to a life that for them is a well life where they they've had cancer but it's hopefully been sorted, and sort of live with it, if you like.